Diabetes ketoacidosis or non-ketotic hyperglycemia are two of life-threatening and acute metabolic complications of diabetes. Our annual average here in the States is about 100,000 per year that patients get hospitalized for diabetes ketoacidosis. And both conditions are part of the continuum of hyperglycemia with or without ketosis or ketone accumulation. So what are those two conditions? They both can occur in type 1 and type 2 diabetes. 2 to 8% of all diabetes hospital admissions here in the U.S. are for the treatment of DKA. It increases in the past decade by about 30%, and we are not sure what's exactly causing that significant increase. Annual incidence is about 5 to 8 episodes per 1,000 patients and appear to be again on the rise. There are still mortality rates are low, but they're still significant, and more so with non-ketotic hyperglycemia than with ketoacidosis, as you can see by the numbers that DKA is less than 5%, but non-ketotic hyperglycemia still could be approaching to 15%. Prognosis is worse in the extreme of ages and presence of either coma or very low. So I think we're still on that same slide, and I'm sorry for all the technical difficulties. So the diabetes ketoacidosis as initial presentation can occur in about 15 to 20% of adults as initial presentation of diabetes, and about in 30 to 40% in patients specifically with type 1 diabetes. So what could precipitate the occurrence of DKA or non-ketotic hyperglycemia? Infection is the most common one, and it could be any kind of infection. Most common ones are pneumonia or urinary tract infection, alcohol or drug abuse, silent myocardial infarction. We see that often, especially in patients with diabetes, pre-existing diabetes. They are not able to necessarily feel the pain from the chest, for chest pain from the heart attack, but the high blood sugar could be the first manifestation of the heart attack and not being able to bring those down. Stroke, pancreatitis, trauma, different medications, steroids being the most common one. Higher dose of thiazide diuretics, although we rarely use the high dose nowadays, and different antipsychotic medications. Hot weather over summertime, and I guess in your case would be even more common, and insufficient water intake in elderly patients, or insulin just getting bad from the hot weather, non-compliance with insulin therapy, and that's primarily affecting patients with type 1 diabetes. So what is the pathogenesis of diabetes ketoacidosis? There are three main conditions that are kind of lumped together. Those would be hyperglycemia, acidosis, and ketosis. So when they all get together, this is the DKA, diabetes ketoacidosis, happens. So there's some sort of precipitating event. At the same time, there's a decrease in the insulin production, but increase in the counter-regulatory hormones, including cortisol and glucagon from the pancreas, breaking down the fat tissue, and also breaking down the protein. That all creates this extra substrate going to the liver, and liver making the new glucose, gluconeogenesis, contributing to hyperglycemia. Plus, there is, due to the insulin deficiency, there is a decreased glucose uptake in the tissues. High blood sugar flowing through the kidneys, causing dehydration and osmotic diuresis. And again, because of the fat tissue breakdown, lipolysis, release of the free fatty acids, ketone formation, increased ketone in the blood and the urine, that all contributes to acidosis. So ketoacidosis is a pro-inflammatory state. Severe hyperglycemia triggers macrophages to produce cytokines such as tumor necrosis factor alpha, interleukin-6, interleukin-1 beta, and CRP. There is an decrease in insulin secretion, at the same time increase in the insulin resistance. And this free fatty acid release from the fat tissue breakdown, because of the inability to utilize the glucose, further contributes to insulin resistance, impaired nitric oxide production, and dysfunction of the endothelium and the blood vessels. So what are the differences and similarities between non-ketotic hyperglycemia and diabetes ketoacidosis? Diabetes ketoacidosis is associated with severe insulin deficiency, and that's what contributes to the ketone formation. On the other hand, in non-ketotic hyperglycemia, there is usually moderate insulin deficiency. So there is some insulin being produced, and there is only 10% of the concentration of insulin needed, to very small amount, to suppress the ketone formation, comparing to how much insulin needed to be able to grab the glucose from the blood and bring it into the cells. There is a higher concentration of free fatty acids in DKA, and again, lower concentration of insulin, comparing to non-ketotic hyperglycemia, where there is a lower concentration of free fatty acids and higher concentration of the insulin. In terms of the clinical presentations, and some, again, differences and similarities between those two conditions, first, polyuria, polydipsia are common for both. Weakness, common for both. Weight loss, common for both, but more present so in DKA than non-ketotic hyperglycemia. Nausea and vomiting, because of the ketone accumulation, would be in DKA, but less so or rare in non-ketotic hyperglycemia. Abdominal pain is, again, more common in diabetes ketoacidosis. For the physical signs and symptoms, hypothermia could be in both. Hypotension could be in both. Tachycardia would be in both because of the volume depletion. Too small breathing, ileus, could more so in the DKA. Acetone breath only in DKA, and very minimal, if any, in non-ketotic hyperglycemia. And altered sensorium or altered consciousness could be in both, depending on the degree of the severity of the condition. For the presentation, DKA usually presents with more acute onset that develops over hours or a few days, versus the non-ketotic hyperglycemia usually days to weeks. Non-ketotic more in the older age and more common in type 2 diabetes, rather than DKA more common in type 1 diabetes. Neurological symptoms could be in both, but again, it's more common in non-ketotic hyperglycemia because the plasma osmolality reaches to over 320, 330 milliosmoles per kilogram more commonly in non-ketotic hyperglycemia than in DKA. Interestingly, the DKA frequently presents with abdominal pain, like a stomach flu, and that the higher the degree of the ketosis, the more common this symptom that we see. On physical examination, we see all the signs of volume depletion, decreased skin turgor, decreased dry oral mucosa, low jugular venous pressure, and low blood pressure, hypertension. More in DKA, we see those fruity odor due to its exhaled acetone, ketone, deep respiration, small breathing, and 25% of patients can present with coffee grounds, emesis, showing or simulating the gastrointestinal bleeding. This is usually due to just stress gastritis, hemorrhagic gastritis. Those patients do not need to have endoscopy. It's usually resolved with the resolution of DKA. Mental status, as we said, it varies from full alertness to lethargy or coma. Temperature could be normothermic or hypothermic due to peripheral vasodilation, and hypothermia is a poor prognostic sign. So for the laboratory evaluation, we order plasma glucose, BN creatinine, serum ketones, Electrolytes, we've calculated anion gap, and serum osmolality. So our lab provides us already with a calculating anion gap. I don't know if you already get that, but if you don't, the formula is chloride plus bicarb, and then sodium minus this the sum of the chloride and bicarb. For urinalysis, we check for possible infection and also check for urine ketones. ABG is useful, and because it's a painful test, venous blood gas is acceptable. CBC was differential, although knowing that WBC, the white count, may be increased just because of the dehydration. Electrocardiogram is important because, as we said before, that silent myocardial infarction can be present, especially in patients with longer-standing diabetes. Bacterial cultures of blood and urine show out infectious cause as a precipitating event. Hemoglobin A1C is very useful if it has not been done within the past 3 months, and chest X-ray is indicated if there are symptoms of possible respiratory infection. What are the laboratory criteria for the diagnosis of ketoacidosis versus non-ketotic hyperglycemia? Glucose, usually lower levels in DKA, over 250, and non-ketotic hyperglycemia usually present with fairly high blood sugars over 600. For the pH, there will be more of the acidotic in DKA and could be normal in non-ketotic hyperglycemia. Bicarb would be low, less than 15 in DKA, and could be normal or very mildly low in non-ketotic hyperglycemia. BUN would be much higher in non-ketotic hyperglycemia. There's a higher degree of the dehydration. Osmolality would be higher in non-ketotic hyperglycemia because the blood sugar would be much higher. Again, ketones in the blood and serum would be more frequently present and a higher degree in DKA than in non-ketotic hyperglycemia, although small ketones can be present. And anion gap would be elevated significantly in DKA and usually normal in non-ketotic hyperglycemia. So we have this definition as mild to moderate DKA when bicarbonate is 10 to 18 and pH is still over 7.3. For laboratory measurements, usually sodium level is low due to elevated plasma osmolality, and we can correct for serum sodium using 1.6 times 100 milligram per deciliter of glucose above 100 to the measured sodium. So it's so the degree of hyponatremia or low sodium may not be as bad when you correct for hyperglycemia. For plasma potassium, usually body is profoundly deficient in potassium because of the loss of potassium in the urine. But in the blood, it could be moderately low, less than the whole body deficiency because of the lack of the insulin or not being able for the insulin to bring the potassium into the cells. The plasma phosphate usually low, and again, it's because of the loss of the phosphorus in the urine, and also acidosis leads to negative phosphate balance. So the main goal of the therapy is correction of dehydration, correction of hyperglycemia, electrolyte imbalance, and identifying precipitating factors and frequent monitoring. So for care for diabetes, so again, one most important factor is give lots of fluids and correct for electrolytes. Measure intake and output to make sure you're matching those. Monitor serum electrolytes closely. Monitor for vital signs for dehydration, for tachycardia, and orthostatic hypotension. For the fluid therapy, again, this is one of the most important, the first therapy that we introduced in DKA and non-ketotic hyperglycemia. The fluid deficit is about 3 to 6 liters in DKA and 8 to 10 liters in non-ketotic hyperglycemia. So we start with normal saline usually, and you can give 15 to 20 milligrams per kilogram per hour in the first hour, or just give us a bolus 1 to 1.5 liter. And then reassess. If sodium is normal or high normal, or high or elevated or normal, then you can switch to half normal saline. If sodium is still low, then continue the normal saline, and you can use 5 to 15 milligrams per kilogram per hour of the rate of the fluid infusion. Now, what is the most also extremely important, when glucose is down to less than 250, change to glucose solution. So you need to add the dextrose, the D5, in order to keep insulin infusion, because you need to clear the ketones, or you need to close the gap. So the only way to close the gap and to resolve the acidosis is to continue with the insulin. So therefore, the target for our blood sugar for DKA is not to get down to normal, but actually to keep as to 150 to 200 and up to 250 for non-ketotic hyperglycemia. As for insulin therapy, you can give it insulin as a bolus, or you can just give the infusion, approximately 0.1 units per kilo per hour, and then titrate it. So the serum glucose should fall by about 50 to 70 milligrams per deciliter in the first hour. And if it doesn't, then double the rate of the infusion. And again, the important part is if blood glucose drops to less than 250, add the dextrose to IV fluids in order to allow for the insulin drip to be going and to continue with the closing the gap and clearing the ketones. Electrolytes replacement. That's, again, it's a very important part of the treatment of ketoacidosis. If potassium is less than 3.3, all the insulin infusions should be on hold, or if you have not initiated insulin yet and potassium is already 3.3, do not initiate infusion until potassium is replaced. Again, this is critically important because those patients can go into severe arrhythmia from low potassium, because as soon as you give the insulin, more potassium would be entering the cells, which can cause profound hypokalemia and precipitate deadly arrhythmias. So again, I think in our hospital and everywhere, also the physicians and nurses are concerned about non-giving insulin, but this is safer to hold it or to postpone the insulin until potassium replaced because of that reason. So give 40 milliequivalents potassium per hour and to replace it first to at least potassium over 3.3 before you reinstall or reinitiate the insulin. So you're still treating the patient, you're giving the fluids, you're giving the potassium replacement. When potassium is between 3.3 but less than 5, already start with giving 20 to 30 milliequivalents in each liter of normal fluid of potassium, because again, insulin is driving potassium in the cells and reducing potassium in the blood. If potassium level is over 5 to begin with, which is common because again, all the potassium from the cells is now in the blood, before you start giving insulin, you don't have to give potassium right away, but watch closely every 2 hours because it's going to drop. In terms of the bicarbonate, if pH is over 7, do not give bicarb. Insulin blocks the lipolysis and resolves ketoacidosis itself, so without the need of bicarbonate. Phosphate, there is no value of giving replacement of phosphate unless it's really low, less than 1. Then you can give 20 to 30 milliequivalents of K-phos adding to the maintenance fluids. So monitoring is important. Check the blood sugars every hour and check electrolytes. Again, as we said, venous gas is okay to check every 2 to 4 hours. Venous pH is only 0.03 units lower than arterial pH. So keep that in mind, and it's okay to follow the venous pH because, again, ABG or arterial blood gas is very painful. Follow GAP to monitor for resolution of ketoacidosis. Ketones may take over 36 hours to clear, so don't measure ketones anymore, just remeasure the GAP. So the criteria for resolution of GKA for glucose less than 200, bicarb over 18, venous pH over 7.3, and in part 1 is normalization of the GAP. So if GAP is still on the borderline high or elevated, do not discontinue the drip. So when all the criteria are met for resolution of the DKA, then you can discontinue the drip. So one and most important part of that before discontinuing the drip is to give a subcu insulin before turning off the drip and overlapping the time of the subcu insulin with the drip. And timing of how much to overlap depends on which insulin we're using. So I'm happy to send the slides and to share them. This is kind of the recommendation summary from American Diabetes Association, and it pretty much goes over what we've just discussed about the management of the diabetes ketoacidosis. Now, the chart includes, I'm just going to point you out to this part of the table or graph. It's possible to use subcu insulin if you don't have the access IV or patient is really hard sick. There are studies showing that it could be effective, the same as effective as intravenous if you follow those patients really closely. So you can start with 0.2 units per kilo as a subcu bolus, and then give 0.2 units per kilo subcu every 2 hours, and you check glucose every 1 to 2 hours. And serum glucose, again, it's the same kind of principle as follow the same as your other management that we've discussed. So transition to subcu insulin when patient is alert, able to eat, and again, overlap with at least 2 hours. This is from ADA, from American Diabetes Association. So don't rush it, as it did take the resolution of DKA, non-ketotic hyperglycemia takes time. So if patient has been on the drip only for 2 to 4 hours, just keep it longer. You need to have the blood sugar stabilized and to have the drip plus minus the unit stable for at least 3 to 4 hours, plus all the other criteria that we've discussed about before you can switch the patient from the drip or intense management to the regular subcu injection. So it has been shown that the average time required for resolution of DKA is up to 18 hours, and non-ketotic hyperglycemia 9 to 11 hours. But we've seen the higher the blood sugar presentation, the longer it takes, and the higher the ketones, the longer it takes to for DKA to resolve. How do we switch from IV to subcu? Always try to make changes in the morning. Don't do it at midnight when everyone is tired and alertness of the staff is not as good. Use insulin infusion for the past 24 hours, but usually we say use the rate for the past 3 to 4 hours and then extrapolate to 24 hours. So for example, if the rate over the last 3 to 4 hours was 1 unit per hour, then use as 24 units times 24 as a 24 units as a total daily dose. So if meal is planned, you can give Lispro or Aspart or Humalog or Novolog insulin or whichever short-acting insulin you have and administer it 10 to 15 minutes before the meal. You can turn off the drip after subcutaneous short-acting insulin is given, but also give the NPH insulin 1 to 2 hours before the drip is stopped. And if you're using the longer-acting insulin such as Glargine or others, it should be at least 2 hours before the drip is stopped. If patient is not previously on insulin, it's not a new onset diabetes or something was precipitating it, schedule sub-Q insulin infusion. If patients requiring more than 2 units per hour, if not, you can just start with short-acting and then see what are the requirements for the insulin. So we just talked about how to calculate the dose. So when we calculate the total daily dose, use as 50% as a basal insulin, which would be long or intermediate acting, and 50% divide between 3 meals. And they use corrected dose as needed. So the recommendations from ADA were introduced in 2012, and we're using the same recommendations, that adding a scheduled insulin dose to patients without prior history of diabetes and blood sugar over 140 with persistent requirement of corrective dose within 12 to 24 hours after the drip is stopped. So meaning if you have not scheduled the prandial dose because you are concerned that patients' insulin requirements are low, if you're seeing that within the next 12 to 24 hours there is a persistent requirement of the corrective scale, you can add that corrective scale as just a scheduled pre-meal dose. Our American Diabetes Association every year comes with the recommendations and updates. So the updates were this year and the same from last year is to check hemoglobin A1C for all patients with diabetes or hyperglycemia admitted to the hospital, if not done within 3 months prior to admission. Basal insulin or basal plus the bolus correction insulin is preferred for non-critically ill patients with poor oral intake and for taking nothing by mouth. An insulin regimen with basal, nutritional, and correction component is preferred rather than using sliding scale alone. For sliding scale alone treatment, very strongly discouraged. And important thing is plan for discharge recommendations at the time of admission already. So that you have time to decide which medications your patient is going to go home on, provide enough education for those patients before they get discharged, not at the last minute. We have now, I don't know if you are using the medications, the new class of drugs, which is the sodium glucose transporter inhibitors. So we're using them for type 2 diabetes and rarely using them for type 1 diabetes. So what we can see in patients who are using those medications, those patients can present with this new kind of entity that we call normoglycemic or euglycemic decay. So blood sugar would be normal, usually less than 200. It can be in both type 1 and type 2. There are 73 cases reported by last year. I think there are way more now. It could be more presented in also, besides the patients who are on this medication, it can be present in pregnancy, in the state of prolonged starvation, in the alcohol abuse, or patients partially treated with the insulin. So the medication for this, the one that I mentioned, SGLT2 inhibitor, it blocks the glucose reabsorption in the proximal tubule and lets glucose flow into the urine, and pretty much patients will pee out the glucose. The pathophysiology of this is that glucose level goes down, and this is insulin independent. It's just the release from the urine. But because glucose level goes down, insulin level goes down, glucagon level goes up, and all the same things that we discussed before, ketone formation, fatty acid production go to ketone formation, and the decay can happen in the setting of normal blood sugar. How do we manage those patients? We suspected, even when blood sugar is normal, in the setting of acute illness or a patient is being on those medications, hold the medicine and advise patient to hold the medication periodically during the prolonged fast, or if patients are on very low carb diet, start low dose of insulin, and you can start IV fluids with dextrose, with sugar at the same time, and monitor closely. So patients can develop non-anion gap acidosis in the recovery, and it can happen within 24 to 48 hours. So monitor bicarbonate and electrolytes till bicarb normalizes. So that's the euglycemic decay kind of concludes my talk.